Welcome back. If you're joining us right now, this is the Daily Report on the third day of the brand new year, a brand new month. And we thank you for joining us. Now, we've got something for you, an interview that certainly is something you need to listen to. The Ministry of Health says that it's made strides in registrations of Kenyans into the new Social Health Authority Fund. Ann Odida, our reporter and presenter, had a sit-down with the Principal Secretary of Public Health, Mary Muthoni, on this matter and other issues, and presents to us this wonderful interview. Let's take a look.
All right, karibu sana PS Mary Muthoni to TV47. How are you?
I'm very well, thank you.
My name is Ann Odida. We are very much honored to be here.
You're most welcome to the Ministry of Health, Ann.
Thank you. Asante
And
sana.
you're looking bright.
You are too. Asante sana. So maybe you can start us with telling us what your docket.
In the Ministry of Health, we mostly deal with the masses. So you must look bright every day.
Yeah.
Even if you meet a patient, when they see the brightness, they will leave out all the worries that they have had.
You have to keep smiling.
And you have to keep smiling and giving everybody hope. You are like the mother of all the issues in society.
Right.
And that's why we are always happy at the Ministry of Health.
All right, so maybe you can start us off by telling us what your docket fully entails. Yes.
Well, for the record, this department is called the Department of Public Health and Professional Standards. Just like the word is public and the health. And our main mandate is prevention, promotion, and protection. And when you go to professionalism, we look at regulation of standards among the healthcare workers, the workforce, and equally among the products that come into the country. And possibly even the infrastructure that we have in the facilities. So when we talk about prevention again, we are talking about the preventable diseases that can be emerging and re-emerging in our society. And the promotion of the same, educating the public. Remember, I can see you're a bit young, but during my time, if you opened the TV, you would find the poster for Ukimwi Inaua. AIDS kills.
Right.
So again, the same case, because they are emerging diseases right now. We can talk about mpox, we can talk about other diseases that are in there and educate the masses about them. And of course, protection. Look at our borders, both the main borders and also there could be porous borders where we could have influx of people and animals into our country that can be a danger and a risk to our health factor. When we move to professionalism, we are talking about the healthcare cadre, starting all the way from the doctors, the clinical officers, the nurses, the nutritionists, regulating these cadres and ensuring that they are adhering to the professionalism and what they were trained in school. It is important to note that most of these cadres must be licensed for them to practice or for them to operate on any human being. And that is why you have seen the other day we had to close some facilities because of undergoing an operation that went sour. Probably because there was an issue. We will be making the report public on what has happened to that. Again, there is a standard. There is a standard operation in terms of establishing a health facility, whether it is a chemist or it is a hospital or a clinic, run by a clinical officer, run by a doctor, run by a business person. There is a standard way, and we are the people who regulate that, and we are able to license the same through our Kenya Medical Dentist and Practitioners Council. And that all, we are able to be very keen on what is happening with the people, because we have discovered that more of the problems that we have at the society, they are actually preventable. If they are diseases, they are preventable. May it be waterborne diseases, you simply just need to take clean water and safe water. May it be vector-borne diseases like malaria, you simply need to sleep under a net. And may it be diseases like cholera, which are brought by that. You can prevent.
So speaking of
Polio.
prevention, how are
Yeah.
we now well prepared as a country for these emergencies, let's say pandemics or just emerging trends? Mpox, we have Mpox, we have cholera, like you're saying. So how are we prepared to avert these diseases?
I'll give an example of the recent disease that we have had, which is Mpox,
Right.
and how we have been able to tackle, how we've been able to show that we are prepared for any kind of disease. If you look at Mpox, which is the Ministry of Health has implemented a multi-pronged approach in managing Mpox as the outbreak of Mpox. One, we have enhanced our surveillance in terms of human resource, in terms of equipment, in terms of the points of places, and up to the county level. So surveillance is continuous of what could be happening at the border points and any other place, even in our own villages. And when we talk about surveillance, we want to know what are the indicators that could be bringing some risk in our society. Enhanced screening. If you go to JKI today, anybody coming into the country is always screened. Sometimes they don't know. I don't want to go to that. But anybody who enters into this country is screened automatically. We know the body temperature, and if we realize that it's a bit off, we will isolate you and get deeper on what could be causing this. We have been able to we have been able to do a lot of contact tracing. If it is a contagious disease, then we must be able to do contact tracing from one person to the other, wherever you passed through. For instance, Mpox, I said, I'll give an example with Mpox. When you get through Malaba border, first, you are screened. Secondly, if we realize that you have the disease and you are in Mombasa, we will pick each and every person you came across from when you entered the border, and we will have them go through the same process, have diagnostics and samples taken to the lab to ensure, just to be sure that it is not a confirmed case. We have enhanced our laboratory capacity. During COVID, you remember many of the samples would be taken to South Africa so that we could confirm whether it is a COVID case or something. Right now, Mpox, we are actually having it done here. We have in our labs that are taking the samples and confirming to us. That's why out of the 329 samples, only 29 have been confirmed as Mpox, of having Mpox case. And remember, when we talk about capacity, we are talking about a network of labs. We are talking about KEMRI, CDC, our National Public Health Lab. And this network of labs, they work together. That if you are in doubt, then move that sample to the other lab for confirmation purposes. So enhancing our labs for real-time confirmation of cases is also an indication that really we are ready for emerging issues that can come into our country. I want to say that we have a very strong network of partners who come on board, starting with the WHO, CDC, both US and Africa CDC. And this is to share information, technical advice, and resources. With the fiscal space that we have as a country, sometimes we not work alone. In fact, all the time, we may not work alone. So we have to bring on people so that we can share information what is happening in Tanzania. Remember, diseases have no boundaries. If there is an outbreak in Tanzania, Arusha here, you'll find it coming to Nairobi.
Right.
Because of equally our nature. We are human beings. We move every time. And the nature of our work is business, relationships, and any other thing that will require you to move from one place to the other.
So what are we doing?
that
Yes,
network.
just stick to that point a little bit. What are we doing as a country now to ensure that we are protected regionally in terms of if we're interacting Tanzania, Kenya, Uganda, that we are not transmitting these diseases?
All these teams work together. In fact, we had our team go for a whole month in Lunga Lunga to have multi-meetings with Tanzania. Whatever we do here is duplicated to the other side. We don't work alone. So we have to establish protocols and ideas on how we share information. If it's surveillance from the other side, then they are able to share with us. Africa CDC equally releases this information every now and then. In fact, probably on a weekly basis. They give us information of what is happening in other countries in Africa. And we get to know. WHO, they are able to equally give us information globally. So that is how we get to know how do we now navigate in our own small space using the information that has already been given. Should there be lack of technical expertise in our country, then we can seek for that so that we are able to be at par. And it is important to note that in this kind of circumstances, we need to develop guidelines, and especially now when our health is a devolved function.
Right.
And the role of the national government is to develop policies and disseminate the same to the counties for implementation. So we have already done that. We have already also done a comprehensive capacity building for our frontline healthcare workers. Remember, these are the people who come into contact with the patient at a go. So it is important to give them capacity. And capacity comes from in terms of commodities, in terms of information, equally in terms of PPEs, to protect themselves, the protective gears, just to make sure that they are equally protected. We cannot work alone, as I have said. And away from the donors, the community-driven approaches always works. Like during this time of Mpox, which we still have in the country anyway, albeit a bit silent because we've been able to really beef up a lot of protection. Meeting the people, the community, and advancing the same conversation. Mpox, mostly you'll find with people who have traveled in countries where the prevalence is a bit higher. The Central Africa region. So truck drivers again and travelers, frequent travelers to those countries, you'll find they may get contracted to Mpox. Therefore, it is important that you meet that cadre of that group of people and sensitize them. We've done that. We've met truck drivers. We have met the workers that work along that corridor and those border points. We have also met the frequent travelers and the hoteliers, because they are the ones who welcome these people in their the hotels, and equally any other person who is in that ecosystem. Very, very important.
So how does your ministry, your docket, not your ministry, your docket ensures that the health workforce is well prepared to handle these crises?
As a government, I have told you, health is a devolved function.
Right.
We work very closely with the Council of Governors. So whatever else we want to cascade down, all the meetings that are done, then we do it in concurrence with the counties. And even the officers who come, we go to the ground. Sometimes we can go to a county and do the training there. They don't have to come to Nairobi. When we talk about guidelines, these are issues that can be cascaded even virtually. It is not something that you must meet face to face so that you can impact on the same. Yeah.
So I understand
and
that
supervisory.
Also,
I have forgotten. Supervisory. Remember, I've told you the role of the national government is training and establishing of policies, creation of policies.
I want us to talk about one of your focal points, that is the community health promoters, CHPs. What progress have you seen so far with them?
Indeed, the community health promoter is a foot soldier at the bottom of the pyramid. And the one success that I have seen is the rollout of universal health coverage during my time at the Ministry of Health and during this government. And the one sub thing that I have seen under universal health coverage is the rolling out of the community health promoter. The community health promoter is one individual who has been trained, has been kitted, and is paid a stipend. In addition, this community health promoter is given a phone, a smartphone like this one, and that phone has a software that is called the Electronic Community Health Information System. And their work is to move from household to household. Let's just call it from house to house. Because if a compound has many families together, then from one house to the other. And their main role is very simple. Check blood pressure, check blood sugar, ensure they educate mothers on how to take care of themselves and take care of their children. Remind them on when to take their children for vaccination and with the right doses. Ensure they assess the common childhood ailments in the community. And generally, advance health matters, health promotion. Remember what I told you, the role of our department? It's prevention, promotion, and protection. So advance health promotion in the community. They can talk about even tobacco use. They can talk about climate change. They can talk about nutrition value in our society to reduce the lifestyle diseases. So we have trained them intensively.
Who trains them?
We train them, the ministry, in collaboration with partners. We have a curriculum, just like a school. We have a curriculum for community health promoters. So we train them, module after module, on how to teach, to deal with issues at the community level. This bag contains equipment, it contains drugs, and contains many other things that a community health promoter and first aid kit, including a weighing machine, that can be used, and many other drugs, for, all this. So they have been trained on how to use each one of these, all right? Therefore, they can go to any household, be able to take blood pressure, blood sugar, common ailments like malaria, pneumonia, checking on the same, common childhood ailments, diarrhea, and actually tell the mothers on how to deal with it. And if they assess and discover that it is beyond their scope, then they refer them to a health facility. As at this morning, I want to tell you that our community health promoters have been able to register 8.4 million households across the country, out of the possible 12.5 million. According to the last census, we have 12.5 million households in this country. So we've been able to visit and register on our ICHIS 8.4 million households. And out of that, 7.1 million households have been revisited. So the first time they came to your place, and after some time they came to check if you're okay, and still take blood pressure from you. 22.5 million people have been screened for diabetes. And out of that, 264 people have been referred to a health facility for further assessment. So they screened, they checked your BP, and they told you, hey, this one doesn't look so good. Please go to a health facility for your further assessment. 15.2 million people have been screened for diabetes. And out of that, 577 have been referred to a health facility for further assessment. Meaning, we have been walking patients. You don't know you have blood pressure. You don't know you have blood sugar. 339,000 pregnant women have been identified in their routine. So in my screen, I can see they have visited a home where there are 339,000 pregnant women. Out of the 132, they were told, please go for prenatal antenatal clinic. Because most of them, and especially teen mothers, because of the stigma, they do not want to go for prenatal. So when the CHP identifies you, they tell you go for antenatal. If anything, our social health authority is covering that through Linda Mama. So it is important to encourage them. And hence, you see why the community health promoter is important, to unearth the unreachable places. Those are your neighbors. You know
What is the criteria of selection for these CHPs?
I'll
Are they
get
people
there.
with a background in medicine?
I'll get there.
Yes, I know you will.
I'll get there. You will allow me to finish on what they have been able
All
to do
right.
so that we go to the criteria.
All right.
5.9 million have been children under 5 years have been assessed for common childhood ailments. And we agreed common childhood ailments range from malnutrition, diarrhea, malaria, pneumonia. Now, you asked another question.
What is the criteria of selection? Are they people with a background in medicine?
The criteria for selecting a community health promoter is under the county government. They are the ones who select the people who come from common backgrounds, okay? They are neighbors of each other, at least with a level that you can read. You can read, you can be able to advise, because it does not require you to have a skilled, it doesn't require you to be skilled in medicine. Because this is not a professional. This is a promoter. You're promoting health services and health issues. So you're not going deeper. And even you in your house, maybe you have Dettol. What do you use it for? When you cut yourself, you clean the wound and you dress it. Now, it is the same thing. When you go to people who have diabetes, they actually inject themselves. Are they trained? No. It is the same thing. The same things that we are told from the hospital, you can do it at home. So we have gotten somebody to help you. If it is dispensing and reminding you, it does not require you to have a knowledge in medicine so that you can remind me that you need to take your child for injection tomorrow, for vaccination. It doesn't. So a community health promoter is not a competitor of a health care workforce.
Right.
Or an officer who has trained. Those are skilled people. And remember, the skilled people, we find them in the facilities. Okay? The community health promoter, we find them at home. So it is you are in your shamba, you've cut yourself, and the community health promoter will run to you, dress your wound, and tell you to go for tetanus. As simple as that.
The community health policy, 2020-2030.
Yes.
Seeks to formalize CHPs. So what steps are you taking as a ministry to achieve this?
Remember, we have a law, the Primary Health Care Act of 2023 that recognizes the community health promoter. So we have already moved from that. We've gone to the extent that they have been recognized in law. they are able to do, we are able to even train them with the curriculum that we already have. So,
are there any disparities in counties in terms of these CHPs, how they tend to households?
This is a new program, so we do not expect to have had 100% of what, in terms of common issues that we are doing. And the dynamism of county to county, they vary from county to county. And when we talk about, let me talk about the stipend for the community health promoter when we are paying from the national government and the county government. Sometimes you might find a county has delayed because there's a budgetary process. Again, that they have to inject to their budgets so that they are able to pay. So really, nobody will have said, I do not want to pay, or there's a problem in this, but there could be delays in terms of the same. On the same, there was also a delay in terms of how we got into the electronic community health information system. That whilst we distributed the gadgets, the training could have been at different times. So even when some could have joined ICHIS in January, others could have joined in February. But now we are regularizing everything because we are already taking off. We are already gearing up to bettering the program and ensuring that this team is taken care of.
When we talk about healthcare gaps, we are talking about these people in slums who are not able to get access to...
When we talk about health services, and let me say that healthcare may not be complete if we do not have adequate human resource, adequate infrastructure, adequate commodities, adequate equipment, and equally the quality of care in terms of those areas. And each of these areas, we are addressing them in a different manner. First and foremost, I know you've seen the doctors raring to go on strike. And these are conversations that we have gone through many times. And we've told them, calm down. These are different government. And we will deal with each of the issues one by one until we finish. Because health is one of the 5 agenda in the bottom-up transformation agenda. And we must make sure that even human resource is part and parcel of the conversation while we are speaking about health. Secondly, when we are talking about the services that are being offered in the facilities and how people can get assisted, we have already rolled out the Social Health Authority that is going to take care of each and every person in this country. If you look at what used to happen in NHIF, we only used to have a 20% of the population that used to get services through the National Hospital Insurance Fund. But right now we are looking at 100% rollout, 100% registration of families or of households that are going to be benefiting from the insurance cover that we have been able to come up with, the insurance program that we've been able to come up with as a government. And why are we saying this? Out of these 20% who are benefiting in NHIF, they only used to benefit when they go for to higher hospitals. That is level 4, 5, and 6. When you go to level 2 and 3, the primary level facilities where majority of our Kenyans go to seek services, NHIF never used to cover. But right now we have a primary healthcare fund, which is exchequer funded, that will take care of these facilities through capitation of the same. And we have already done part of it right now, as we speak. It's already done. This will help in the improvement of the gaps that we have in these facilities, so that more and more Kenyans are able to access quality services from these facilities. Secondly, we have our Social Health Insurance Fund, which is now going to take care of the secondary facilities, that is level 4, 5, and 6. And in so doing, anybody who is registered into the Social Health Authority must benefit from the same. And we have the final fund, which is all, this shift is publicly funded. It's our Harambe kitty. We've put our funds together, our 2.75, and we are able to reap from that 2.75 to now be able to get services from the facilities that have been authorized to give that. And finally, we have the emergency, chronic, and critical illness fund that is also exchequer driven, which never used to be there. Anybody, even you, if you had an accident and you go to hospital, the first thing that they would tell you is to call your relatives so that we can get a deposit and we can invite the doctor, the specialized doctor, to come and attend to you. So we don't want to go through that. If you have an accident, it's an accident. Walk into any hospital and get treated. If you have a long-term ailment, why should we take you around in circles? Treat the patient and then kesi badai.
We've had cases where people say, some go to the hospital and they say SHA is indeed working, and some say SHA is not working for them. So what really is the problem between these two?
Indeed. And I will tell you for a fact, this is like your project that you start every other day. And sometimes you can even build a house, very beautiful house. But when you get inside, you'll find that the taps are still not running. The water is still not running. Electricity, this dim light. It's the same case with SHA. We've built this house, and yes, we are inside. But we are realizing there are some areas that we can still fix. That's why we are saying, yes, there could be challenges. But this is not forever. And we must keep evolving and ensuring that we fix these challenges on a daily basis. That is why we have a call center. We are able to pick complaints from the ground on a daily basis and resolve them as they come. If you look at my phone today, I have 2 or 3 cases that have been pushed to me. And every time I push them to SHA, they resolve them. The same case. You may not reach me because you may not have my number, but you may reach the common call that is given to the public so that any person with a complaint should call. So this is a confirmation. We don't have NHIF, and we may never go back there. So the very best thing is we work together to make sure that SHA works. And the only thing is you tell me where it's not working. Where did you go to hospital? Were you treated? How were you treated? Was there a challenge? And if there's a challenge, then it is fixed. Otherwise, I would also discourage the masses from generalizing issues. I have a number of times somebody comes and tells me, this SHA is not working. And I ask them, give me an example of where you went to a hospital. Because it is important to be specific on the areas that have an issue. Come and tell me, I went to this hospital, this was the problem, and could you fix it? So that we don't generalize everything. Even the good things that are happening to people are watered down by the few things that could be there. But yes, indeed, we have had challenges. And that is an acceptance.
Yeah.
But if you look at the challenges that were there on the first day, they are not there now. The noise has gone down.
All right, I want us to get now a bit more personal. What are some of the challenges that you have encountered as Principal Secretary for Health?
You want me to go granular? I think we are working at a time when you have to be a little bit more innovative. And especially when we are in a fiscal space where availability of resources is not just there every now and then. You could be having an idea, but if you're not innovative enough to drive that agenda, it may go to the drain, So you see, that looks like a challenge, but it's a good challenge so that you keep thriving and keep pushing. Don't expect the government to give you everything. It is up to you, and it is up to me as a principal secretary to also be innovative enough to know that I can also have additional resources from maybe partners that would come on board to to close in the gap that of where we are. Remember, this space as a PS, you have been given an opportunity so that you can make somebody else's life better. And you have to have the will, you have to have the resilience and the push to achieve that one goal. Otherwise, you would have remained where you were before. But I love the challenge.
So what does success look like for you in this docket?
For me, in the Ministry of Health, success looks like rolling out of UHC to its implementation will be the success. And we are halfway there. I have no doubt that UHC is going to be a reality in this country. And it takes two to tangle. It takes myself, the whole of government approach, the whole of society approach for us to reach there. That is why even in the laws that have been enacted, we have community in those laws as committee members to run the facilities at the bottom of the pyramid. That we as the government are not the ones to dictate what is required in my health facility at the bottom. It is you, the person who gets the services there. You form the committee and then you tell us, this is what we require. And when you get the money, then sit down and decide what is the priority. So I think I am happy. And for me, that's what looks like success. When every Kenyan is able to have an available, accessible, acceptable, and affordable quality healthcare.
All right.
And we are getting there.
Amazing. We are here. We will be there no matter what.
Yes.
Thank you so much, PS, for making time.
I'm going to call upon every Kenyan. I want to wish you a Merry Christmas and a prosperous Happy New Year. But I want to remind you, please remember to wash your hands. Remember to handle your food in a more hygienic manner. Remember to drink clean and safe water. And remember to go for your screening. Because screening is the way to go. Do not wait until you get sick and then we are not able to reverse. Screening is the way to go. If you don't come across the CHP, go to your nearest facility and do some screening.
Amazing. Asante sana, PS. We wrap it up there.